Thank you, Dr. Bailey. Again, you just knocked it out of the park. Well researched, topical, and reminding all of us a little bit of basic medicine that we learned many years ago. Question number one. This is one I think we all think about in terms of stomach acid. Regarding good bacteria from food sources, how well do they survive the stomach acids? Dr. Bailey.
They survive the stomach acids very well because most of these foods initially ingested pass through the stomach very quickly and make it into the intestine. The fiber foods are basically digested in the small and large intestine, not so much in the stomach. The stomach begins the breakdown process, but the stomach is really not going to affect the bacteria whatsoever.
Okay, thank you. Next question. Looks like it might be 2 or 3 parts. I'll read the whole thing and maybe break it down if you need to. Would the nasal biome change after someone with nasal airway resistance starts using a mute on a daily basis? As a side note, I noticed increased mouth breathing when wearing a KN95 mask, so I started wearing a mute under my mask. The result is less stress and a big increase in mental energy at the end of the day. This is obviously from a member, so do you need me to read that, or are you okay with that?
No, I'm good with it. The mute is not going to affect the nasal biome whatsoever. It's simply going to impact the airflow. The nasal biome is, again, let me go back for a second. Remember what I said about there are various areas of the body, the skin, the mouth, the nasal and trachea, the airway itself, the gut. They all have different concentrations. I attended a webinar recently on this very topic. The presenter was from the University of Colorado, a guy by the name of Kenneth Wright, and it's spelled W-R-I-G-H-T, very knowledgeable individual in sleep. And he had some slides that actually showed in a colored fashion the differences in where the microbiome were, depending on where you were looking, the palm of your hand, the arm itself or the skin, and so forth. So it's not going to affect the microbiome. It may help to lend some help in stabilizing it. Now, the important thing is with nasal clearance or with nasal rinses is to remove any kind of byproducts that are there, which may help to reinforce the nasal biome.
Okay, thank you. Next question regarding melatonin. I've noticed eyewear companies have been putting blue light filters into daytime glasses. This doesn't make much sense to me since that would be promoting melatonin release during hours when we should be awake. What are your thoughts, Dr. Bailey?
All right, can you read that to me again? When are the blue?
Yeah, regarding melatonin, comma, I've noticed eyewear companies have been putting blue light filters into daytime glasses. This doesn't make much sense to me since that would be promoting melatonin release during the hours when we should be awake. What are your thoughts, Dr. Bailey?
Okay, first of all, that makes no sense at all to put blue light filters into use during the day. The blue light is more of a problem during the nighttime or during dusk than it is during vivid light during the day. Secondly, the melatonin release is just because you stay awake doesn't mean melatonin is not being released. In other words, if you're a shift worker, your melatonin is going to be released at the time when the sun sets. So even though you're going to work at 8 o'clock at night, let's say, or at midnight, melatonin's already been released just as a natural occurrence. This is part of the reason why, as a shift worker, when you come home, the amount of time you can sleep is a lot less, usually about 2 hours less. Excuse me. About 2 hours less because you're not getting the net effect of the melatonin because it's not setting the brain up to receive adenosine and GABA, because that's directly linked also to the circadian rhythm of the brain. So the blue light blockers during the day is absolutely useless. It's not going to affect it's not going to cause melatonin to be released. It's no different than if you had a dark day. I mean, if you lived in Alaska, for instance, and it's the middle of the winter and the sun goes down at a certain hour, melatonin isn't released earlier. It's released more in the circadian pathway at the time when it would normally be released.
Okay, thank you. Have you come across any data between multiple sclerosis and OSA?
No, not between MS and OSA. Between insomnia and OSA, I'm sorry, and MS, yes. Between circadian rhythm and idiopathic hypersomnia, yes, there is literature. I'm trying to dig deep into the tunnels of my brain. I don't believe RBD was associated. Yes, there was an article about REM behavior disorder and MS as well. MS does cause a change in our circadian rhythm. So there are articles out there all about that, yes.
Okay, thank you. Dr. Laurie Jones from Guelph, Ontario.
Does the vagus nerve signal, which potentially can be reduced by muscle contraction of the neck muscles, affect the gut biome population?
I can't answer that definitively. I've not seen anything in the literature regarding that. All of the stuff that I presented today is really within the last 4 or 5 years, new information. There's a lot of research yet to be done. So I don't have an answer for you on that. But I would suspect that the microbiome and how it affects the vagus nerve is affecting it through routes that are associated with the gut-brain axis as opposed to other factors. That would be my assumption.
And not the reverse.
Not the reverse.
Thank you.
Mm-hmm.
Thanks, Laurie. Another written question. There are articles about vitamin D and MS. Comments?
Vitamin D is a very interesting. First of all, we have to understand that vitamin D is not a vitamin, it's a hormone. And as such, it has a very different role. I have one article that I came across on the microbiome and vitamin D, but vitamin D has so many different attributes to it in terms of what it does and how it can affect all of this. But I do think that vitamin D supplementation, mainly through sunlight, alters the microbiome of the skin, and it also has an effect upon the production of vitamin D. So I think there's a very positive effect there.
Thank you.
I don't know if that answered the question per se.
Well, the member has either left or turned off his camera. I know he's very keen to follow up on it. So if there's more to be asked about that, there we come. Dr. Alter, do you want to engage with Dr. Bailey about your question about vitamin D and MS?
Okay. Yeah, there's a Dr. Hollick who's constantly talking about vitamin D being related to a whole bunch of things, MS being one of them.
How is he making that association?
I can send you screenshots of the slides from his video.
What is his name?
Holick.
Is he on YouTube?
Oh, yeah. It's either HOL or HOLL. Michael.
I'll take a look at it because vitamin D has also been implicated in having a big function with the immune system. And MS has come under some attack as far as whether it's an autoimmune disease or not. Or there's some information to implicate it as an autoimmune disease. So there may be something to that. I'll look that up and I'll pass it on to David and he can in turn pass it on to the group.
Thank you, Dennis. Dr. Jones.
Dr. Bailey, you're very much in touch with the status of sleep in United States. And recently, the people in Medicare came out with a report discussing the efficacy of CPAP therapy. Would you like to comment on that?
That report, which came from the HRQ, which was an independent body that looked at all of the effects of CPAP on OSA patients, mainly related to health outcomes. And of course, one of the focuses was on cardiovascular disease. The American Academy of Sleep Medicine came out with a rebuttal, which they were joined with the American Thoracic Society, the American Association, or the American College of Chest Physicians, a variety of other groups. D-ABDSM was another one. I forget the others. But the bottom line is that their reporting was well validated by the use of evidence. And what they reported on is highly accurate, is that when a patient is already diagnosed with a particular health problem, whether it be cardiovascular disease or diabetes, the ability of CPAP intervention on the OSA is not going to have a significant impact on the modification of that disease process. And oral appliances are basically the same. And I believe that a lot of that is because they focus on one modality. They don't focus on a multitude of approaches. And they don't, as the study showed, particularly towards the end of that document, very, very engaging document, they basically explained that the demographics of the patient population they were dealing with was too diverse, that, for instance, you would need to separate out those people who had cardiovascular disease for how long, and those people who, say, were obese versus non-obese, and those people who had other types of issues, whether they had cardiovascular disease and diabetes or just cardiovascular disease. The New England Journal of Medicine back 3-4 years ago came out with a paper that really threw a monkey wrench into CPAP and basically said that if someone has a pre-existing cardiovascular condition, CPAP is not going to change the course of that condition. It's no different than watchful waiting or of routine care. I forget the term exactly what they used. But the bottom line is that particular phenomena is applicable almost primarily to patients with severe sleep apnea. Now, another paper recently came out from the American Heart Association, actually was published in the journal Circulation this year, from the American Heart Association and the American College of Cardiology. And it basically showed that patients who have severe sleep apnea are really the ones that are most at risk for any type of cardiovascular consequence, which comes on the heels of the 1995 paper from Marin and Associates out of Spain, which showed that only severe sleep apnea patients are the ones who are at most risk for cardiovascular consequences. The problem you've got is that in all of these studies, all of these patients were severe patients. Now, in the recent paper from the American Heart Association, they defined severe sleep apneics as an AHI of 36 or greater. Now, that's contrary to what we hear all the time is 30 and up is severe. So their metric for things was different. And herein lies another problem, in that the metric for how we define sleep apnea and the severity of it is changing. In fact, there are 2 or 3 papers now that came out within the last year that show that the AHI is a very invalid metric of the severity of sleep apnea, that other things should be considered. Itamar has jumped on that big time. I don't know if you've gotten some of the things from their advertisements in Sleep Review, but they've come out and basically stated that AHI is not a valid metric, that we need to be looking at other things. Intermittent hypoxia is one of them. If you look at some of the papers that are out there comparing intermittent hypoxia to AHI, they're very close bedfellows. One relates almost exactly to the other. And so we've got a lot of cross relationships that are out there, and people are becoming very suspect of AHI as a valid metric for defining severity. That also was shown in a paper in respirology back a number of years ago, where they looked at the effect of CPAP, oral appliance, or no treatment on AHI, and they found that oral appliance was every bit as good as CPAP. So we're in a changing world very quickly and very dynamically. So
Excellent.
I don't know if that answers your question, Dr. Jones, but that paper certainly got the attention of ASM.
Any follow-up, Lori?
No, I am just in a quandary about that and where I should be situated with regards to providing care for people. And so thank you for the update on the literature. Is it true that CPAP machine therapy needs to be constantly monitored as the efficacy of it in regards to whether it's intermittent hypoxia or AHI changes?
It certainly should be. I mean, that's the purpose of the monitoring devices. What used to be a chip or a smart card in the device, now we have GPS that monitors them in some situations. I don't know if some of the more frequently dispensed ones are functioning that way in Canada. They are in the US to some degree, but not all. Knowing what is happening throughout the night. But the real dilemma still exists, that patients typically don't wear the machine or wear the device for more than 4 hours, 4.5 hours, and they take it off. And when do they wear it? They wear it the first half of the night, which is the wrong time. They should be wearing it the last half of the night, because AHI is typically and almost universally worse during REM sleep versus non-REM sleep, right? I mean, that's what we've known for decades. And so I always told people, I would suggest go to sleep without it, set your alarm for 2 a.m., get up, put your CPAP on, and do the last 4 hours and see what happens. And you see the sleep studies where patients go in and they're there for 4, 5, or 6 hours, and the study says, well, we didn't have enough. Their apnea was worse towards the latter part of the study. We didn't have time to do a CPAP titration.
Right.
With all due respect to physicians, they have overutilized CPAP and not given oral appliances its due. And in this paper from the American Heart Association in the journal Circulation, they give equal merit to oral appliances and CPAP.
Excellent. We have one more written question submitted. If you've got a few more minutes, Dennis.
Fire away.
What does the research say on oral appliance therapy and disease progression like cardiovascular disease? What does the research say on oral appliance therapy and disease progression, i.e. CV, cardiovascular disease?
All of the current papers looking at cardiovascular disease, controlling it with the use of oral appliances, is identical for the most part to CPAP, with one exception, that the oral appliance, even though it doesn't control the AHI as well as CPAP does, it does have a more longevity in terms of hours of use per night. And so its impact upon pre-existing cardiovascular disease is going to be pretty much identical. However, those are very small studies. They're not as prolific as the ones with CPAP. The one area where a study is definitely needed, I don't know where the money would ever come from, would look at the impact of oral appliance and its effect upon atrial fibrillation in comparison to CPAP. CPAP, we know, has a very good effect upon AFib in terms of the patient not requiring additional procedures for cardioversion or ablation when they're on CPAP, but there's no studies on oral appliance and its use for that. So, we do know on blood pressure, there's good studies, or a number of studies related to oral appliance compared to CPAP, and oral appliance tended to have a bigger impact on blood pressure than CPAP did. There was a gentleman a number of years ago, who published a paper, and he had, I'm trying to remember the term he used, but I'm going to use the term corrected AHI. And what he did was he looked at patients and what their AHI was when they were wearing the CPAP and what their AHI was after they took the CPAP off. And he created an algorithm that showed a number he called the corrected AHI. I believe that's what it was called. And basically what he had was, okay, your AHI was really reduced with the CPAP, but when you took it off, the AHI went back up. So here's really where your AHI was. It wasn't what they said it was on the CPAP. So I thought that was a very interesting premise in terms of looking at things.
Dennis, I'm going to do what I don't ever do, is going to ask my own question, because as I sit here listening to you folks, I keep thinking about the number of times central apnea has come up. I sit on our hospital sleep rounds. I hear people talk about it all the time, but anytime I question it, it seems like the elephant in the room. No one wants to talk about it or understand what caused it or how concerned you should be. I don't think it's a very high percentage, but it seems to be some big alarm that I don't know we understand all that well. What's your thought about it?
Central sleep apnea got its name because it was believed that the central mediation of our respiratory centers, particularly through what's called the Pre-Botzinger complex, which is in the reticular activating system of the brain, was impacted by hypoxia, and that reduced our respiratory drive and created these, quote, central events. So where the patient would stop breathing, but there was no legitimate obstruction. So central sleep apnea, even though it occurs most often in conjunction with obstructive sleep apnea, is nothing to really worry about. I feel that central sleep apnea is kind of a prodromal sign of someone who's got an elevated loop gain. No, you're familiar with that term, I'm sure.
Yeah.
That's a term that's used but not well understood. And the way I have defined patients who have an elevated loop gain is these are people who will clinically present as shallow breathers. So they just don't have the deep breath that other people have. And what happens is that they just kind of forget to breathe for a while. And so during the sleep study, that's what happens. Now, central apneas will occur in conjunction with obstructive apneas. Everyone's going to have a few of those throughout the night. It could be a change in neck position. It could be something that's affecting the reticular activating system, whatever it may be. However, and it could be also that the baroreceptors of the brain are not functioning quite properly because you haven't really reached that imbalance, if you will, between the elevated CO2 and the reduction in O2, because they're not one for one. They're not equal, right? We know through basically our respiratory system that as oxygen falls, CO2 doesn't rise precipitously to the same degree. It rises much slower, all right? So basically what we're looking at is a system that could be out of balance, and it takes a while for the CO2, because of the shallow breathing, for the CO2 to rise enough to actually trip off the respiratory center to either trigger the respiratory center to go back to work, or for it to cease for a period of time, take a rest until the CO2 rises enough to trigger that increase in respiratory drive. All right? Everybody okay with that? All right, so.
I knew you'd have a good answer.
Pardon me?
No, excellent. Thank you. I knew you'd have a good explanation.
Hey, there's one other factor.
Okay.
In this day and age, I have to be suspicious of opioids.
Okay.
Because opioids will cause central apnea. So whenever I saw an increased amount of central apnea on a sleep study, I got concerned. But now you have to remember, I was in Denver, Colorado practicing. And in Denver, Colorado, we have another problem where central apnea can occur, and that's called altitude. So patients who are on opioid therapy, more to your part of the world, because you're not at an elevation that's like 6,000 feet. So those types of situations could be someone who's using opioids.
Oh, Dr. Bailey, thank you once again for an excellent presentation. You come super prepared, and you're always able to answer the oral questions, which you're not even aware of until we get here. So thank you again. This is your third appearance in Canada. You're on our short list for return. As I say, we're just launching our fall season, so we'll be in touch. I know you'll be able to keep us engaged yet again.